Well, thank you everybody for sticking with us. In these last two talks for today, we're going to be focusing on narrowing in on the spectrum of GI problems that occur in neurodevelopmental disorders and autism. As we saw earlier, some of these effects can be quite broad and severe. The first speaker I want to introduce is Dr. Kathleen Motil. She's been a long-standing advocate in the Rett Syndrome community, and we're thrilled to have her participating today. Dr. Motil is a pediatric gastroenterologist, and she works at Texas Children's Hospital and Baylor College of Medicine. One of her main focuses is nutrition, and she also has studied the stool microbiome and how that affects families with children with Rett syndrome. She's been a tireless advocate in the Rett syndrome community for the past 25 years. And she's going to tell us today about her observations in that community and what she's learned working with families. Welcome, Dr. Motil.
Well, thank you for inviting me to speak today. Let me bring up my slides. So the title of my talk this afternoon is Growth and Nutrition Difficulties, Lessons Learned from Rett Syndrome. Before I begin, I need to tell you that I am a consultant for Acadia, which is the company that sponsors the trials for trofinetide, and I'm a section editor for Up to Date, which is an electronic medical textbook. I have no financial relationships with companies to disclose, and I'm not going to discuss unapproved commercial products. I do need to disclose, however, that the International Rett Syndrome Foundation has funded many of the studies which I will discuss today in Rett syndrome. My objectives for today are, one, to recognize nutritional deficiencies in neurodevelopmental disorders, and I'm going to use Rett syndrome as the model, to identify trigger signs for assessment, to identify clinical assessment tools, and then to identify approaches to assess those nutritional interventions that might be applied. This slide summarizes the growth and nutritional problems in Rett syndrome. Growth abnormalities, including short stature and malnutrition, are found in at least 62% of individuals. Feeding problems, including chewing and swallowing difficulties, are found in 81% of individuals with Rett syndrome. And low bone mineral mass, particularly low bone mineral density problems, are found in about 59% of individuals with Rett syndrome. Abnormal growth patterns are pervasive throughout Rett syndrome, as you can see with the blue lines on this graphic slide. Weight decreases by 6 months of age, height by 17 months of age, and the BMI is lower than reference standards. The pubertal increase in height and weight are absent in individuals with Rett syndrome. And we know that poor growth is associated with worse developmental delay and higher disease severity. Growth abnormalities are due in part to poor nutrition. Energy imbalance, particularly inadequate dietary energy intake and altered energy metabolism, account for growth abnormalities in Rett syndrome. We know that dietary energy consumption is about 30% less than unaffected individuals. We know that lean body muscle mass is about 15% lower, and total daily energy expenditure and sleeping metabolic rates are equally about 15% lower in Rett syndrome. Energy expenditure for physical activity, including the stereotypies that the children have, are not increased. And we know that energy losses, particularly in the form of malabsorption, is not increased in Rett syndrome. Body mass index is the gold standard for the assessment of nutritional status in Rett syndrome. Body mass index is the ratio, or at least it's represented by the ratio of weight to height. And normal BMI for unaffected individuals is the 50th percentile. Normal BMI, however, for Rett syndrome is variable. In younger girls, normal BMI represents the 25th to the 50th percentile. In younger girls, the BMI, when it is normal, can actually fall anywhere between the 5th and the 25th percentile. The trigger for evaluation actually is a BMI that represents less than the 5th percentile. Another measure of practical significance is the suprailiac skin fold thickness. The tummy tuck, which is the suprailiac skin fold thickness, when it equals approximately 1 centimeter in width, is a good measure of nutritional status and actually approximates the body mass index. Inadequate dietary energy intake due to chewing and swallowing dysfunction accounts for the reasons why we find poor growth in children with Rett syndrome. The swallow function study is the gold standard to assess the functional performance of chewing and swallowing difficulties, and the risk of aspiration can also be evaluated by the swallowing study. The trigger for evaluating children with a swallowing function study is the queries related to choking with feeding or drinking and prolonged feeding times greater than 40 to 60 minutes. The approach to intervention for major weight loss or feeding refusals includes alternative feeding methods that are either enteral feeding tubes or button gastrostomies. The indications for thinking about alternative methods of feeding include a body mass index less than the 5th percentile, progressive decline in the body mass index greater than 6 months period of time, chewing or swallowing dysfunction, including aspiration pneumonia, or parental request when they have difficulty with feeding refusal, medication, or fluid administration. This slide illustrates the growth response after nutritional rehabilitation with gastrostomy feeding in Rett syndrome. Height velocity and weight velocity increase after aggressive refeeding, and these values can actually exceed the normative data for height and weight velocity. The approach to intervention for chewing and swallowing dysfunction is limited. We recommend generally occupational therapy or speech therapy for refeeding and practice with oral motor skills. We know that oral motor skills wane with advancing age, and the motto is, if you don't use it, you lose it. Thickeners can be recommended for thickening of thin liquids, but appetite stimulants generally are not indicated. We have limited anecdotal evidence of benefit with Vital Stim, but again, these types of interventions require additional study. Low bone mass is another problem in Rett syndrome that is related to nutrition. Total body bone mineral content and bone mineral density are lower in Rett syndrome compared with unaffected individuals. Low bone mass is associated with increased risk of bone fractures, and the prevalence of fractures in Rett syndrome is approximately 30% by the time our girls get to be 25 years of age. This prevalence is actually a fourfold greater risk of fractures in Rett compared with the general population. Low bone mass results from osteoblast dysfunction or decreased bone formation. Mice models of Rett syndrome show decreased numbers of osteoblasts, abnormal growth plates, and decreased cortical, trabecular, and calvareal bone formation. Bone studies using labeled tetracycline in girls with Rett syndrome showed decreased trabecular bone and slow bone formation rates. Osteocalcin levels in individuals with Rett syndrome show uniformly low osteocalcin levels across the age groups, as shown in this particular slide. We know that dietary deficiencies with respect to calcium and vitamin D are prevalent in Rett syndrome. We know that calcium intakes less than 90% of the dietary reference intakes in Rett syndrome are about 28%. The fractional calcium absorption is higher in Rett syndrome than unaffected individuals, and vitamin D deficiency in Rett syndrome is about 20%. Dietary calcium supplementation in Rett syndrome, when we exceed the dietary reference intakes, is associated with increased bone alkaline phosphatase and osteocalcin levels in prepubertal girls, again supporting bone formation. We know that the use of multiple vitamins, the use of commercial formula supplements, and increased numbers of servings of milk is associated with increased vitamin D levels in these individuals. Food frequency questionnaires that address servings of milk and dairy products and the use of multivitamin and mineral supplements is a useful parameter to address bone mineral mass issues. Laboratory tests such as calcium, phosphorus, ionized calcium levels, and parathormone levels usually are normal, but are ways to monitor bone mass issues. Serum 25-hydroxy vitamin D levels may be low, and serum 125-dihydroxy vitamin D levels may be increased in individuals with Rett syndrome, again supporting the increased need for dietary calcium. Dual energy X-ray absorptiometry, or DEXA, is the standard method to assess total body bone mineral content and total body spine or hip bone mineral density, but its use may be limited. This particular tool is difficult to perform because stereotypies often lead to motion artifact. Sedation may be required for adequate output of the data, and the DEXA often requires intervals greater than 1 year of study for outcome assessment because of the slow rate of bone mineral deposition in children with developmental disabilities. With respect to the approach to intervention, few guidelines exist for the approach to low bone body mass interventions in Rett syndrome. Non-pharmacologic interventions include dietary and physical activity interventions. Pharmacologic interventions include the bisphosphonate drugs, but long-term outcomes and issues like atypical fracture rates really are unknown. The approach to intervention often resides with dietary reference intakes for age, for calcium, which we recognize, milk and dairy products as monitored by their consumption and their relevance to reference intakes are good sources. We can monitor this by questionnaires. And when children do not tolerate milk and dietary products, calcium supplements can also be noted and used as part of their assessment protocol. The approach to Vitamin D deficiency, again, resides with the dietary reference intakes for age. Food questionnaires, again, are useful tools. Sunlight exposure and frequency of milk exposure are as good vitamin D sources are useful questions to ask. We can monitor exposure duration, and we can monitor serving sizes by food questionnaires. Again, when these sources may be deficient, we can always request information about supplement about vitamin D for any levels that are less than 20 nanograms per milliliter. The physical therapy interventions, again, reside with time elements. Non-ambulatory children can be monitored by supported standing with standing frames. They can be monitored with low magnitude mechanical stimulation platforms. For those children who are ambulatory, body weight assisted treadmill or assisted walking time studies can be used to assess their progress. So in summary, nutrition problems, including growth failure, malnutrition, feeding difficulties, low bone mass, are common in neurodevelopmental disorders, including Rett syndrome. Nutritional problems often are caused by inadequate dietary energy, calcium, and vitamin D intakes, as well as chewing and swallowing dysfunction. Diagnostic tools and intervention strategies can be useful measures to assess in terms of their clinical outcomes and quality of life measurements. So I will stop here and we'll wait for questions later.
Thank you, Dr. Motil. That was fantastic. I think it's great to have nutrition be a part of this too. It's something that we often overlook when we're busy talking about constipation. All right, so our next speaker is Dr. Kara Margolis, and she is somewhat of a rarity in pediatric GI, in that she's also a very accomplished basic scientist, something we definitely need more of. She's an international expert in how neurotransmitters affect the GI tract, and she focuses on their role in children with autism. She's currently a professor at Columbia University, and we're very happy to have her here and to tell us about the much more scientific part of these disorders. Welcome, Dr. Margolis.
Thank you, Bill. I'm just going to share my screen. Okay. So I first off wanted to thank the organizers for letting me be a part of this. It's been, a real pleasure and honor, not only to hear everyone else's talks, but really to hear the family perspective too, which I think is so important, as a physician and as a parent. So thank you for letting me be a part of this. And I'm sort of happy to give the last talk, which is unusual because I feel like between the 3 talks that came before me, that it sort of gave a lot of background to what I'm going to go into today, which is the brain-gut microbiome access in autism spectrum disorders. So my disclosures are that I consult for Scioto and Biomica, and I serve on several editorial boards, but those are not reflected in the talk I'm going to give today. And as Bill said, I'm a pediatric gastroenterologist with a clinical interest in gut-brain axis disorders, and really chief among those is GI problems in children with autism. And I've been really fortunate to be able to segue my clinical interests into a research focus, looking at this relationship between gut issues, the brain and behavior in autism, with a more recent focus on the microbiome brain-gut axis, and I'll talk a little bit about that today. So I just wanted to start with a quick patient presentation of a child I now saw quite a few years ago. He was a 17-year-old with autism who came to me with a history of recent regression. So 6 months prior to his visit, he was verbal and was really a genius, both in math and reading. He went on a family trip to India where he caught a gastrointestinal bug, which presented as diarrhea for 5 to 7 days. And while the diarrhea resolved with antibiotics, his behaviors radically changed. He became completely nonverbal and stopped the reading and math, which he loves so much. He also developed these severe obsessive compulsive behaviors, one of which was compulsive water drinking. And he was actually admitted to the intensive care unit several times because of water intoxication. But upon history and physical, I noted that he had a variety of signs and symptoms that are related to what we see sometimes in kids with autism and GI distress. He banged on his chest, he had excessive drooling, and he had really difficult stooling with self-disimpaction. So I treated him for severe constipation and gastritis, and all of these relatively acute onset behaviors resolved once his GI conditions were treated, including that obsessive water drinking and also that catatonic-like behavior. So I'm gonna, what Kent and Andre talked about at the beginning was that individuals with autism more commonly are diagnosed with GI conditions. The clinical presentations of GI distress can be dramatically different than kids that are typically developing. And it's important to understand these distinctions, not only for diagnosis, but also treatment, which I'm going to focus on today, because treatment options, as we know, are highly limited in many. And even if we can treat the GI condition successfully, a lot of times challenging behaviors persist. And we've seen increasingly that gut problems are linked to behaviors, mood, and cognition. So, as Ken said, a lot of these kids, we think, as opposed to having a brain disorder, have a brain-gut disorder, and treatments need to consider both, and gut-brain treatments are highly limited. So what I'm going to talk about today is really just quickly review the gut-brain axis and then the microbiome's role, addressing the question, is there a specific autism microbiome and can we fix the gut microbiome in autism? And then go a little bit into nutrition in autism. How is nutrition linked to the gut microbiome? How can diet in autism be studied in a way that reflects the diversity of individuals with ASD? And finally, a little bit on our research of whether a nutritional intervention may actually be able to change the GI and behavioral outcomes in children with autism. So the gut-brain axis, which Ken and Andre both referred to in their talks, really is this continuous bidirectional communication, which links gastrointestinal symptoms in autism to the behavioral symptoms. And there's been a lot of work done on the gut-brain axis, but 3 major mechanisms have been studied more than all the others, and that includes serotonin, the immune system, and bacterial molecules, or the gut bacteria. And like I said, I'm going to be focusing on bacterial molecules today, not only how it relates to nutrition, but bacterial molecules have a very strong interplay with gut neurotransmitters and modulators. And so peripheral serotonin is one of them and is really another expertise in my laboratory. So what is the gut microbiome? On the simplest level, it's basically the ensemble of bugs in your gut. And so the gut microbiome is huge. There's over 100 trillion microscopic life forms living in your gut. And so it's not only huge, but it's incredibly complex and individualized. The microbiome's as personalized as a fingerprint. So no one person has a microbiome that's exactly like another, or at least that we're aware of. And this is a phylogenetic tree. So what it does is it looks at all the different types of all the different autism studies over a 10 to 20 year period, which look for microbiome differences in individuals with autism compared to those without. And what you can see here is that there are differences in many of these studies, but what you also see is that the differences are very different from one another. Once again, really emphasizing this fact that there's no one unique autism gut microbiome. So how do we fix the gut microbiota? And this slide shows a lot of the different attempts that have been tried. And, probiotics is one of them, where you give one bacteria or a group of several bacteria to the gut. But a lot of clinical questions remain. So which gut bacteria are the one that actually work? How much do you give? And there's a trillion bacteria there. So what are your targets? Different bacteria, as we're seeing through research, really has different effects, both in the gut and the brain. So figuring out which one affects which systems is still a challenge. Similar with the microbial metabolites, so what the kinds of sort of chemicals or neurotransmitters that probiotics or any sort of bacteria give off, the same clinical questions arise. Which one, how much, and again, which ones target problematic behaviors or could be potentially be dangerous or not helpful. So another approach has been, let's give all the bacteria through fecal microbiota transplantation. And that's really giving stool from a quote healthy individual to somebody that has a medical issue. And so one study has been done in this in kids with autism. It was a small study. It had very exciting findings that it did seem to improve even long-term gut and behavioral outcomes. But that study needs to be optimized. We need a larger study, something where there's a placebo control, because we know in prior studies where we look at autism, that placebo does make an effect, and other issues like that. There's also transfer of unknown bacteria. And so there's been a number of studies now which have started in sort of the preclinical or animal study realm, but even in humans now, that when you transfer unknown bacteria, you might not only have good effects, but you could have negative effects. And some of those that have been shown include mood, obesity, infection, and more recently, even potentially autoimmune disease. So finally, we go to diet, and there's been a lot of talk of which, or alluding to nutrition, and Kay certainly talked extensively about that in Rett syndrome in the talk right before mine. And the reason diet's attractive is because it's very challenging to feed a lot of children with autism, but what factors are modifiable that we can really use to change that gut microbiota? And what you can see from the figure here is that most of these are not modifiable. It's hard to live in a specific geographic location for this reason. You can't alter host genetics or your aging, or even the way that you were delivered as a baby. But there's a couple here that can be attached, like exercise, stress, but diet is something that's readily approachable. And as Andre alluded to in his talk earlier on, autism, there is highly complex, and really no one child or adult with autism is like another. And so really, when you have an autism-based study, you really need to consider that diversity in autism. And this was one study published a couple of months ago in Cell, which really looked at this and finally considered all these different variables. So they looked at the clinical backgrounds of these patients, what medications they were on. They looked at nutrition to some degree, and then they looked at the stool microbiota. So again, their study confirmed this finding that there's no one unique autism-associated microbiome. But what they did see was an effect on diet. So they saw that when individuals had a less diverse diet, so that means less variety in the diet, that led to a less diverse microbiome, and that led to looser stool consistency. That was measured by one bowel movement taken. And so really what this showed is that autism-related dietary preferences, or really food variety, mediate autism gut microbiome associations. So this was definitely a big step forward in being able to sort of say or recognize that autism is complex. But there are a lot of questions that this study didn't address. There was really no dietary detail with regards to gastrointestinal or behavioral outcomes. And diverse is a very general term. It doesn't answer the question, which foods or food groups should you ingest or avoid? And it was also one stool sample, which as a gastroenterologist, we know can vary between diarrhea, constipation, and as Ken talked about, diarrhea can sometimes present as, constipation can sometimes present as diarrhea. So you really need to get a better look at that. And so it's important to do this too, because as you see here, all these different components of diet have very different effects on the microbiota. And this really needs to be looked at more in depth in children with neurodevelopmental disorders. So a study that we have been intimately involved in, and that was funded by Autism Speaks, is beginning to really look at all this. And, I'm going to, before I introduce the study, say that I'm going to give general big picture findings because we're writing it up right now and I can't talk about the details, but I want to give hope to families and say that I think the studies are out there. It's a multi-center study. Ken Williams was the principal investigator at Nationwide Children's. Tor Savage, who's by Texas Children's and who Dr. Motil knows well, as Ruth Ann Luna, are there. And at UT Southwestern, Dr. Powell was there, and I've been the principal investigator at a residential center for kids with autism called the Center for Discovery. And I put Ruth Ann Luna's picture up in the upper right-hand corner because she is the principal investigator in this study. So almost 250 children were recruited. About 50% have autism. The remainder are neurotypical. And we did a comprehensive evaluation of all these kids. So comprehensive behavioral assessments through 4 different studies, in comprehensive gastrointestinal assessment, food diaries for 2 weeks, and looked at all those different active medical issues and medications. Took a stool specimen and then looked at the microbiome, and again, that metabolome, so those chemicals or neurotransmitters that the microbiome can affect or be affected by. And then did something called a multi-omic analysis, which is allowing us to look at how specific parts or which specific bugs in the gut microbiome or which specific mediators in the metabolome correlate with gastrointestinal problems, behaviors, and other medical issues, and nutrition. And while I have nutrition listed last there today, I'm really going to be focusing on nutrition. First, as a result of the study of the 3 outpatient populations that we looked at, and then looking at a dietary intervention with the Center for Discovery. So what was seen in these kids from outside, again, the Center for Discovery, was that when you look at food diversity or a food variety score, what you see is that these kids with autism that you have highlighted in that bluish purple color have a lower food diversity compared to both their siblings and typically developing kids who are not their siblings, but it was significantly different in those kids who were typically developing and unrelated. And unlike the paper and cell, we saw no significant microbial associations with stool consistency, likely because of the things Ken talked about and the idea that we looked over a longer period. However, importantly, we saw microbiota differences or food variety differences associated with other GI-associated symptoms, including increased severity. And we also saw in this large population increases in behavioral challenges with GI symptoms across all groups. So then we looked at these microbiota differences and looked for correlations with specific dietary components. And ASV is just a fancy name for a state-of-the-art way of really being able to detect the different microbiota. And what we saw was that there were several ASVs that were associated with these increased food variety scores. And 28 of them correlated with 24 different behavioral variables. So you can see here some of the behavioral variables we see, including lethargy, touch sensitivity, sensory seeking, compulsive behavior, and irritability, really showing that different microbiota may modulate different types of autism-associated behaviors. And similarly, we saw others that correlated with core diagnostic features of autism, including, I have listed here, stereotypy, really showing that this supports a personalized approach to really how to do research with these individuals and also potentially for treatments. So to determine whether nutritional intervention plays a role, we again looked at this residential autism population with an in-depth dietary intervention. We compared them to age and sex-matched subsets, both in the outpatient autism population as well as the typically developing kids. And then what we found was significant improvements in gastrointestinal symptoms and behaviors observed in this residential cohort compared to the other cohorts of kids with autism. And they were significantly associated with differences in both the microbiome and the metabolome. So first, what you can see is that, again, in that bluish purple, you have the kids with autism who are on the outside of the Center for Discovery. And in red, you have the kids within. And what you can see is that their food variety scores are much increased compared to the kids with autism, and actually, and no different from the typically developing kids. We saw microbiome differences at multiple levels. I'm showing here the phylum and the genus taxa levels, and we saw that they were related to not only food diversity, but also specific food groups, both when we compared the kids with autism in and outside of the Center for Discovery, and also in the kids with autism versus those that are typically developing. And then we saw differences in metabolites. So this is something called a principal component analysis. And each shape there represents an individual, and where they're located on the figure represents their entire gut microbiota and sort of where they're related. And what you can see is that the kids at the Center for Discovery have a very different metabolic profile compared to those kids outside the Center for Discovery with autism and those that were typically developing. However, there were limitations to this, and that there was really, this is called a cross-sectional study. So it was really a snapshot at one time for all of these individuals. And that leaves us with limitations. Do the behavior and GI outcomes influence the gut microbiome or the metabolites? Or on the opposite end, do changes in the gut microbiome and metabolome from, say, diet affect behavior and gastrointestinal outcomes? So what's needed is a prospective longitudinal study, and we are doing a prospective study like this right now, but of course it's in the very preliminary stages. So in conclusion, GI problems, as everybody on this call knows, are common in autism, and the treatments for GI issues in individuals with autism can be complex because autism itself is highly complex, but brain-gut interactions are likely involved in many cases. Gut microbiota may be a target for both GI and behavior issues in autism, and maybe even the core features of autism. There is no autism microbiome that's been detected thus far, but personalized approaches in research and treatment, I think, are going to be key based on this study and that other one that I presented here. And families need more specific guidelines and more targeted approaches. So interventions that can be implemented in line with the challenges of autism certainly are warranted. And nutrition may be an option as we begin to cipher out exactly what we need to give. And more specific nutritional interventions may change the course of autism, not only the core traits, but also behavior and gastrointestinal outcomes. And again, types of foods may make a difference. And like I said, I'm highly optimistic. There's more to come, hopefully within the next few months after we submit this paper as well. I just want to thank the team at the Center for Discovery that really has helped lead the clinical studies from my side. And of course, I've highlighted in yellow here the key collaborators on this study. And of course, my major collaborators in other areas. Science is done in a group, which is why I appreciate a meeting like this, which brings together people from different backgrounds. And of course, I can't do anything without my research support. And so now that we're done, I'll take any questions. Thank you.
That was fantastic.
Billy, I think we have a question here.
We do? Okay.
Instead of diet modification / increased food diversity, can some of the same gains be made by adjusting prebiotics and probiotics? Do you see this as a potential therapy going forward?
Sure. I think that it can. We have a lot of work to do. I think that, nutrition may be almost, and this is taking into account that I understand that nutritional intake can be a real problem in these kids or adults. But nutrition may not affect just one bug. It may affect 20 or 30 different bugs or 3,000 bugs. And we're trying to figure that out. So I think a lot of it is going to depend on how many bugs are affected, who they're affected in. I think that a more reasonable assessment may be that we may be able to have, say, pre or pro, or now postbiotics are a newer thing or emerging too, that may target specific traits that are associated or specific behaviors or specific gut issues rather than tackling everything at one time. And that's why I talked a little bit more about this personalized approach.
Great. Billy, you had a question?
Yes. So, and I think this is a question for both of you. So one of the goals that we have is we'd like to help inform future program announcements and RFAs from funding agencies about what the community of both families and scientists want money to be spent on. And I'm wondering if both of you could comment on what guidance would you give program officers and others writing program announcements? What how should we be spending resources, and what general areas should we really focus on to move all of this forward?
Sure. Go ahead, Kay.
Okay, so I think you have to think in terms of what your goals are. Do you want to do the basic approach, or do you want to do, which really leads you into future long-term thinking? Or do you need to do something here and now while everyone is looking for longer term curative type results? Much of the work that I have done up to this point has been the here and now. What can we do to help our families improve the quality of life of their children here and now? Because so much of the curative aspects involve basic work that will take a much longer time period. So I would say the first thing you do is sort out where are your priorities for the monies that you have. Here and now, more appropriate clinical work versus longer term avenues, such as, for example, the microbiome. If I weren't so old, the microbiome would be near and dear to my heart as well. We've done some of the studies in Rett syndrome as well. And one of the things that can certainly be expanded upon is looking at the metabolome as well. In our girls with Rett syndrome, we have some very distinct differences between affected and unaffected individuals when we look at the amino acid type metabolites or the precursors of the neurotransmitters. And I think that's an avenue also that needs to be explored for the long-term consequences. Dr. Margolis didn't talk about the serotonin aspects of the gut microbiome, but she knows as well as many of us know, there are many neurotransmitters that are different in affected individuals compared with unaffected individuals. And so how you can interrelate one diet to the microbiome, and 3, the metabolome, and then 4, the behaviors, is a very complex analysis that requires numbers of children in a particular study. And so I think you do have to think about multi-center studies as well, as Dr. Margolis has done. I think that's an excellent outcome with so many people that have been included in her studies, which is very difficult to do. It sounds like it should be quite simple to collect a stool sample, but it can be difficult because parents have many things on their hands, including the care of their children.
I actually can vouch for that. My daughter was a participant in that study through Baylor. And we got all the materials thinking, oh, this will be really easy. And it was more of an ordeal. I was like, yeah, I'm a poop doctor. I can collect poop. That's a really good point. And I think it speaks to the fact of making sure that we're being inclusive in research. And we typically approach research as how we would in a typical population, as far as the implementation side of things. So I'm glad to hear you mention that.
Well, and certainly, when you have an engaged audience, and that is so, when our families recognize what we're doing and why we are doing it and what we need, many of them really do come forth, and it's commendable with all the things that you have to do to take care of a child with special needs. I think it's commendable when our parents are enthused, excited, and engaged in the work that we do. And we can't thank them enough because we really do need our families.
So I think just to build on what Kay just said, I mean, multi-center, different geography, different levels of autism, and family, and organizational input. I think that the advantage that the study I presented had is that Ruth Ann Luna is very vocal about the fact that her son has severe autism. And so having somebody in the planning stages that understood, and even with data analysis of what the limitations were, and planning our prospective study, which is actually all kids with severe autism, it was so helpful to have her guidance in terms of what we could and could not do, and what the reasonable expectations were for families who, I think a lot of times want to be active participants, but, really struggle. I think, we lack, so I think multi-center large studies are critical given the diversity. I think we miss a lot with neurodevelopmental disorders and the severe end of them because they're the hardest patients to get samples from. And so there's not a lot of studies looking at that. And when we actually try to quantify behavior severity or autism severity, there's really no great scales to objectively take that into account, which is, which can be a very challenging thing and would naturally exclude families that can't do that, or if we can't make it applicable, make it easy for them to participate. I think,
Dr. Margolis, I would challenge you to go ahead and develop your autism GI quality of life or gastrointestinal health questionnaire, which is what we basically had to do in Rett syndrome. And we're trying to expand that to other MECP2 disorders. But the reality, you are correct. The reality is there is a very broad spectrum within any specific disease entity or disorder entity. And so in order to, again, narrow down what may be affecting the outcome of your different parameters, having a tool that does look at the individuality and then the group as a whole in terms of the spectrum of the disorder would certainly help.
Sure. I think appreciating the complexity, and I think that's a relatively new concept, not amongst the families and not amongst the physicians that treat these families or work with them, but the idea that, neurodevelopmental disorders are not just the brain. There's many other medical issues, and they're not necessarily all at least known to be neuron or nervous system related. And so I think appreciating that and being able to separate that out is also going to be critical when studies are brought forth. Anybody that wants to just study autism as one label and promotes that and submits a grant like that, that should be knocked off the bat right away, because there's just, it's not, no disease state, as we're learning, is one disease state, and certainly neurodevelopmental disorders, as we know, are far from that.
I think the other thing that all of you can think about is having statistical input from a statistician who not only understands the math and the multiple complexity analyses that you need to use when you're dealing with something such as a microbiome, a behavioral input, a metabolome input, and then a clinical characteristic input, but the statistician or the statistical support system needs to be able to understand the biology as well as the mathematical components. And so often that's a very difficult person to find, because the statistical support entity is often not based on a multidisciplinary approach to helping research activities. So I think that's also a very useful consideration when you're thinking about how do you spend your money.
And just a plug for Calliope, who is actually really working towards developing these screening technologies that are also, building upon, what we published on, but going many steps further into really figuring out the right ways to screen children with neurodevelopmental disorders.
It's a strong argument for more and more collaboration. I think we're all, like, all of the stakeholders are strengthened when we do that. Heidi, I think we're going to move to the next session now.
Yes, and thank you both, Dr. Motil and Dr. Margolis. I think you've highlighted. Dr. Jimenez Gomez put up a slide that had limitations, and one of the things that's been a ongoing theme is the ability to measure meaningful change. So we'll continue to move forward working on that and hear about it tomorrow from Dr. Calliope Halling. And we have one more session. So thank you all for sticking with us. Dr. Bennett will be reflecting on what we've learned today and what we'll be doing tomorrow. So thanks to everyone for joining us today. And if you'll go to the next session and join us for a recap, we will see you in a few.